Vignesh sir.
Naresh?
Yes sir.
Okay. Everything okay, la?
Yes,
You
yes
check.
sir. Sir, you are connected to laptop or mobile?
I connected through laptop only.
Laptop only. Okay, fine. I'll make you co-host. Okay.
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 And yesterday, one of the doctor calling. I think Ram sir told you, no?
Yeah, already I had word with him
No
yesterday
problem.
only.
Okay. If someone asks some support means, please you come into the discussion. Okay.
Okay, okay,
Bye.
okay, okay. Hello, Vignesh sir.
Yeah, Naresh.
Sir, if any doctor face issue na, like sharing presentation, then tell them
Ah,
to share that slides to you or me. Then what we can do from backend, we can change the slides.
okay. But sharing slides in immediately that can't be possible because the file size will be much bigger. So
Okay.
that is it. So
Mhm.
let us check. Huh? Anyhow,
Okay.
no issue.
Okay. Okay. Okay.
Sir, welcome, sir. Good evening, sir. Sir is joining, sir, in few minutes, sir.
ஒரே நிமிஷம் எனக்கு ஆடியோ எப்படி செக் பண்றேன் நான்
Okay.
ஓகே
Sir, good evening, sir.
Good evening, yeah. Good evening.
Ram.
Sir, Ram Kumar this side, sir. Sir, I think actually a lot of time actually you can start, sir. You can give a formal introduction about this event and you can invite all chairperson, panelists and all the thanks presenter and actually we can go with the presenter, sir. And first presenter actually Kalai is there. Will you please, sir, introduce, sir.
Okay.
Hi, Kalai, sir.
Hi.
Hi.
Yeah. Good evening, everybody. I welcome all the people, speakers, and also all the discussions and panelists for this online meeting. I thank Abbott people. So we will have today two talk, OCT guidelines on acute coronary syndrome, chronic coronary syndrome by Dr. Kalai and another expert talk on OCT and ISR will be by Dr. Palanivel Rajan, and the case presentations will be by Dr. Nitish Kumar, and one other talk, OCT in ACS by Dr. Balaji. And so I welcome Kadresan sir, Armugam sir, Kalai all of you, Dr. Palanivel Rajan, Dr. Arun, everybody to this meet. So shall we proceed or shall we wait for somebody to join? Ram?
No, sir, we will go ahead, sir. Please invite Kalai, sir. Actually,
So, okay, I invite, so this is mainly regarding the usage of imaging, especially OCT in acute coronary syndrome and chronic coronary syndrome. And most of us are using OCT in chronic coronary syndrome, especially severe calcium lesions, bifurcation, left main, and any other true bifurcation, long lesions and all. But there is some amount of what you call inertia, cardiologist inertia in using OCT in acute coronary syndromes. But the data and lot of studies are supporting the lot in ACS, especially in bringing down the dissection, major dissection, covering that, preventing in-hospital and long-term stent thrombosis rate, and also reducing this under-expansion, stent sizing, and malopposition, and even the tissue protrusions. So this in ACS, it has its role. So let us see how the speakers and the case presenters will bring out all these things. So first I invite Dr. Kalai to present OCT guidelines on ACS and CCS. Over to you, Kalai.
Thank you, sir. Thank you, Abad, give me the opportunity. See, directly I will go to my discussion. Good evening to all my friends, senior colleague, and everyone. So I will share my screen. The screen is visible, I think. So my talk for another maybe 10 to 15 minutes. The guideline for management of coronary disease. What is the role of imaging in the patient going for percutaneous coronary intervention? I don't want to go to this detail. We know that when there is a recommendation for anything is a class 1, class 2, class 3. Class 3 it is not recommended. Class 1 is it's must to give the benefit to the patient. Class 2A definitely should be considered. Class 2B is maybe considered. So what is the key takeaway here? If you see the patient undergoing for complex lesion angioplasty, particularly left main, true bifurcation, long lesion, and we can include a patient going for stent failure also. these are the things we have to compulsory to use intracoronary image guidance by usage of IVUS and OCT, which is now is 2024 EAC guideline. It is a class 1 and the level of recommendation is A. So we should keep in this mind. So any patient with ACS undergoing coronary stent implantation, especially left main artery or complex lesion in the form of left main circumflex iliac bifurcation, very long lesion, stent failure, CTO, or if we are going to use multiple stent, definitely intracoronary imaging, either intravascular ultrasound and OCT recommended for procedural guidance to reduce the future ischemic event. What is advantage of like OCT when compared to IVUS? So the specific special advantage to assess the calcium thickness and lipid presence. And when compared to IVUS, we want to see the amount of thickness, whether it's superficial or deep, thickness of the calcium, everything. OCT is definitely edge over when compared with the intravascular ultrasound. And lipid presence, thrombus formation, fibroathema, and especially patient with ACS when they're having the plaque erosion or rupture, particularly helpful in patient with acute coronary syndrome. And in the patient going for acute coronary syndrome, if you want to see the stent start new interval thickness, apposition, edge dissection, definitely OCT have a special advantage when assessing these are the morphological feature or pre-procedure, post-procedure outcomes. So what is the OCT evidence? So if you see the data support for image benefit, over 14,000 patients with intravascular imaging data solidify the importance of intravascular imaging should be the gold standard care for better patient outcome. If you start from Illumin 4 when compared with the OCT guided PCA versus angiogram guided in complex PCA, and if you see the October study, it's mainly the OCT guided PCA versus angiographic guided, especially in the complex bifurcation where it is total number is 1200. And most important thing is the initial studies, like optimal PCA study, it's a small study, OCT guided PCA versus IVUS guided PCA. But finally, in 2023, it is a major study like Activus, where they included 2,800 patients, and they see that is there any non-inferiority of OCT guided PCA versus IVUS guided PCA, and the network data analysis again it compare OCT guided PCA versus angio guided PCA, and finally Occupy. These are the large body of data available to support the usage of intravascular imaging in patient going for complex PCA, left main PCA, and fibrocation PCA, long lesion, and patient with acute coronary syndrome also. So one by one, I can go very general. This network meta-analysis, the image guidance substantially improve the patient outcome. They include almost the analysis 12,400 patients, and they analyze for 20 trials of OCT, IVUS versus angiographic evidence. All the thing is, if you see the cardiovascular death, target lesion failure, all MI, stent thrombosis, target lesion revascularization, everything, the image guided PCA having statistically significant clinical benefit when compared with the angiographic guidance. So this meta-analysis proven very clearly. It is not like 100% we have to use for angiographic image guided PCA. Some of the indicated patient, especially patient with complex situation, left main intervention, stent failure, left main fibrocation, long lesion, and chronic total occlusion. And if you want to see the pre-procedural outcome in patient with ACS, definitely image guided substantially improve the patient clinical outcome. And here, if you see the Illumin 4, it's mainly the comparison of image guided PCA versus angiographic PCA for all included patient. It's not only see the comparison of only complex, it is include all cases where the increase in the minimal stent area by 7%. If you compare the angiographic PCI versus OCT guided PCI, definitely statistical a gain of MSA by 7%, where it is associated with reduced complication in the form of reduction of major dissection, reduction of major malapposition, and reduction of major tissue protrusion and untreated focal segment disease. Where sometimes if you have missed the major dissection or major malapposition or major tissue is more prone for stent thrombosis. We know that stent thrombosis is actually associated with higher mortality when compared with native myocardial infarction. So if you see the OCT analysis, the major malapposition, major dissection, acceptable stent expansion by more than or equal to 90%, definitely the OCT arm having 40% higher when compared with the angiogram one by 23%, and major tissue protrusion also we can tell. So definitely all the image guided procedural safety result also, the OCT arm is better with the angiographic guided PCI. And if you see the safety result, again, whenever there is a no major dissection, no major malapposition, and there is a no major tissue protrusion, it is almost equal to no stent thrombosis. If you have stent thrombosis, definitely the mortality rate on the higher side, that will long up to even 95% of the patient have death or MI within 2 years when stent thrombosis occurred. If the patient is survived, they may land up in severe left ventricular dysfunction. So if you see the safety result again, the OCT guided versus angiographic guided, especially in the complex angiographic lesion, here they include the complex lesion substudy. Out of 2,400 patients, the complex angiographic lesion OCT guidance resulted in major larger MSA, greater stent expansion, and have resulted in fewer major procedure complication and reduced serious MACE event. These are the mainly for when there is a stent length is more than 28, severe calcification, ISR, CTO, and two stent bifurcation technique used. So this is another important study where that the OCT guided PCI versus angiographic guided PCI. Again, if you see the all-cause mortality, cardiac death, and target lesion, myocardial infarction, all that's statistically better with the OCT arm. Here they, in October study, they mainly included is a complex bifurcation lesion. They include mainly specifically for highly complex bifurcation lesion. Equally divided, it is a multi-center studies and randomized control study. They specifically look for what is the image guided PCI, especially OCT, when compared with the angiographic PCI. How it is the role of this image guided PCI, better clinical outcome for complex branching point lesion or bifurcation lesion. If you see the both in OCT guidance in complex, in OCT guidance in bifurcation, definitely in the Illumin 4 as well as in October study, the 1 year outcome, almost 28% reduction of lower MACE event when compared with the angiographic PCI, guided PCI. So finally, when there is at the end, when we are performing the final OCT full backsode, definitely lower incidence of MACE event. Whenever we are doing the OCT guided PCI, sometime we may stop to 1 or 2 studies, then we may not because of lack of time, or we are not able to do the final OCT pullback. But this slide is specifically is made for when performing the final OCT pullback, so definitely lower incidence of MACE when compared with no final OCT. This another studies showing the innovate complex lesion, where is specifically look for OCT guided PCI versus angiographic guided PCI. Definitely again, if you see the clinical significance of end of reduction of primary infantile is higher with the OCT guided PCI. And if you see the all the important trial like Illumin 4 in October and Renovate complex PCI, definitely the OCT guided PCI for all cases significantly reduced at stent thrombosis, In October study is mainly for complex fibrication lesion. It showed superior to angiographic guided PCA for major adverse cardiac event at the end of 2 years follow. And if you see the renovate complex PCA, the composite outcome is better with image guided PCA in the form of reduction of target vessel MI or cardiac mortality when compared with angiographic alone guided PCA. This is most important. Another thing is Activus study. They include almost 2,800 patients and 1 year follow-up. This is they compare with IVS guided PCA versus OCT guided. This is the major important studies. So it showed that there is no major neck to neck studies. But if you see, this is a active studies only the comparable result between OCT and IVS, where it's proven that the non-inferiority of OCT guided PCA when compared with the IVS guided PCA. The p-value for non-inferiority less than 0.001. So the contrast usage higher with OCT, but without increasing the contrast-induced nephropathy. This is a major first study showing the non-inferiority of OCT when compared with the IVS guided PCA for complex percutaneous coronary intervention. This is another important OCT in ACS resistive state and tactics. Also, the ACS cause defined by OCT stratifies the reduced risk of MACE event. The optimal, again, important patient with the AMA undergoing PCA. This study is 8 center in China. They compared the prospective multi-center observational study. Again, the clinical outcome when compared with the angiographic and OCT PCA is better with the OCT guided PCA in patient with the acute coronary syndrome. And cardiac death also statistically less with the OCT guided PCA. This is the last one, Atlas OCT. Again, it's an ST elevation MI patient treated by OCT guided PCA is mainly the single arm prospective investigator initiated multi-center registry. Again, it's proven that the feasibility of OCT guided PCA higher and component of OCT guided PCA like morphological assessment, stent size, stent optimization, everything is favor for this. So in the imaging matter as a conclusion, if you include all the meta-analysis, studies and trials, everything, the superior outcome for imaging, the guidance compared with the angiogram, almost 31% reduction of target lesion failure and safety benefit also 52% reduction of stent thrombosis, 20% reduction of all-cause death and 18% reduction of BMI. And OCT improve the procedural and patient clinical outcome. Its superiority in achieving the MSA, which is larger with OCT guidance. And the superiority is benefit not only patient with the routine PCA, in patient with the complex PCA, patient with the left main fibrication, left main stenting and stent failure and ACS. And it always associated with reduced complication like fewer major dissection, fewer major malapposition, fewer major tissue protrusion. And there is no clinical difference between IVS and OCT. And the OCT guidance is non-inferior to IVS guidance in achieving the target vessel failure at the end of 1 year. The contrast usage are higher, but there is no major evidence of increase in contrast-induced nephropathy. This is the last one, the AI powered Ultron 2.0 software, the fast and efficient, customizable, simple, easy to use, and the software powered by AI. And I conclude my talk. We can discuss further.
So that was a nice talk, Dr. Kalaiselvan. So I invite inputs from Kadresan sir, chairperson, and Armam sir and Mohan Mani.
Good
Sir,
evening.
sorry, I got joined late actually. Sorry, good evening everyone, and I welcome all for this wonderful educative forum. Kadrisan sir, good evening.
No issue,
And,
Mohan. Later on the latest talk.
Sir, not like that, sir. I have actually one more primary. I just
Okay.
want to join. I listened it, and I'll be back again anyway. But collection, Kelvin, as you said, the Ultron 2 is ultimate. There's no question at all. because
Okay.
it has its own values. Because of it can produce all your inputs without you need a customized guide near to you to learn everything and put into the bag, because that itself is make sure that your length of the vessel, where is the calcium, so what is the length of the calcium, the thickness of the calcium, and everything will get A registered, and it will get give the all the pictures to you. So it will be easy for the thing. What will happen is, if you do like that with Ultrian 2, the main advantage is your time will get a slowdown, because the measuring time. Suppose if in ACS, we always tend to do either a pre or post OCT situations. So those things you can be avoided by doing the thing by quick pull in, pull out, because everything will give the thing. You can decide easily that what kind of stent or without stent you can able to manage everything. You can able to see the thing. That is one thing. That is because of the last one which I see in the slide. And the second, all the things, your Octavius trial, all your other trials which have been shown, which has already been proven. The subsets of all the your coronary artery disease, like dissection planes, long segment lesions, CTOs, and osteal lesions, bifurcations, calcific lesions. These all the thing which is being proven, just previously it was there in the class 2A, then now become a class 1. So that is the one bigger advantage with the optical coherence tomography for all the indications. So in that way, the trials, whatever which have been shown, the October trial or Octavius and all the trials, so remains same. And regards to IVS versus OCT, again, because IVS been there for very, very long period. Kadiran sir and all, as I know, Singh has been using it for a very, very long time actually. And the OCT has been bit later, but even though the upgraded versions of all the OCTs give a little upper hand, but the OCT and IVS trials, yes, obviously it's a non-inferior to the IVS. There's no question at all. See, nowadays, we are, once you used for that OCT, you can do the saline OCT. You know how to do the saline OCT without contrast, how to, even if it is a 4-size vessel, you can able to do that. There's no question at all, actually. So, I personally feel the thing, even close to the IVS, you can do all the subsets, especially osteal. It's not, it's been always a very difficult subsets to do that. And distal left main and other subsets, yes, of course, yes. And even a shorter left main, yes, you can able to do the thing. Even if it is osteal lesion with a shorter left main, you can able to do the thing. So this is what my personal observation, and maybe the others can tell more about regards this.
Good evening, everybody. I think Kale covered all the points very well. So the important point in our usual cases and in also complex cases is to identify and make sure what is the block characteristics. So if you can understand the block characteristics, you will have an adequate lesion preparation, and you will also know what tools we have to use for the preparation. So one problem with the complex PCI is either you overdo or you either underperform. So optimal performance can be achieved by using the imaging, particularly OCT, because we know how to modify the calcium, what is the thickness of the calcium, and when the lipidic block is there, how to avoid the no flow reflow situation. And also, particularly in stent failure cases, we'll know the mechanism of the stent failure very clearly. And I think particularly with the complex PCIs, to achieve the mean stent area and also to do the kissing inflations properly. And the one important point highlighted by Kala is the final OCT run we should always do, because sometimes what happens inadvertently, our OCT catheter would have caused a stent deformation also. That was also very well documented in the October trial. So we should make sure that we correct everything and have a very good final OCT to make sure things have gone well. That will be my comments. Thank you.
Whether in acute MI there will be presence of spasm, whether it will help in sizing of the stent.
So yes, sir, I want to answer for that question actually, because ACS situation, yes, OCT definitely can be done very comfortably, but only rule is you have to use more and more JTN and Nicorandil, and make sure that you are getting the T3 flow. You can use, if it's a 100% occluded vessel, please use the thrombus section and make sure that your the thrombus has been cleared, and with the T3 flow, with the more amount of GTN and nicorandil, especially some 300 microgram of GTN and nicorandil of 10 mg, always will give a help for to get into the exact size and the size. Normally, you will know there will be a vasospasm will be there, and there will be a the vasoconstriction will be there. It will maybe a undersizing of this one, but if you use more and more GTN and nicorandil, I personally say it will be, you will get the very good result. Actually, you can avoid the slow flow, no flow if you do in the proper way of this thing. It's called a slow inflation, slow deflation technique, whether it is a pre-dilatation or post-dilatation, and stent inflation or all the thing.
Harmon,
The question
sir,
is, sir, dose appears to be a large dose compared to conventionally we think, the NTG and the nicorandil. Whether we can use that much of dose, sir?
Yes, sir. Because even in a hypotensive patient, what we used to do is in our center, we always will connect it with an noradrenaline with the support, and we will give a more amount of this thing. But you have to give it a slow, slow manner. You can use 100, then subsequently another 100, then another 100, then another 100. You can able to use it. So you can manage it, sir. It not been a much problem won't be there. Unless surveyed so much hypotensive with cardiogenic shock, anyway we are not going to use the OCT. So there is some subsets you can avoid it.
Harmon, sir, actually, when the length of lesion is less than 40 millimeter, usually we don't get an issue. We get with NTG good dilatation and the spasm relieved. Your question is very valid. When the lesion in LAD, the ACS is having a long lesions, no, there we get into trouble when you put the OCT catheter, even as Mohan said, in spite of lot of NTGs. There one clue is, if you see that the EEL will be well seen. If you are able to see thick EEL, that shows that the artery is under spasm. So that time you can give still more NTGs, but it is really challenging if it is a diffuse LAD lesion with the ACS. Otherwise, less than 38 millimeter stent planning ACS, most of the time we don't have issue at all when you give a NTG. But it is a concern when it is a long lesion, for example, LAD.
Okay, sir. Okay, sir. Okay.
And sometimes if you are doing a very complex PCI in a very ACS situation and you are not able to image properly, you can even stage imaging. I think in few cases we also do the imaging after 2 days or 3 days where the flow is improved, and then you can optimize that itself before discharge. So that is also valid in very few cases where you have to be very clear on all of those.
Yes, sir. Today I had one patient, 55-year-old antral MI, mid and distal LAD, tandem 99% lesion was there, but proximal to mid LAD highly calcific 80%. So what I did is I just stented the mid to distal with a 33 millimeter stent. Then I took a OCT. I was able to avoid the thing, and there was severe calcium, circumferential calcium 270 degree in proximal and mid. So with aperta and good cutting balloon, I am able to get out that. So in such a situations, if the distal is highly thrombus and proximal severe calcium, you can fix that lesion with stent and then take OCT, and then real area where the calcium is there, we can do that also.
Yeah, too.
So we'll go to, I think Dr. Nitesh has some emergency and he's not joining. So we'll, I call upon next Balaji sir to give talk on OCT in ACS.
Sir, Arunachalam sir, shall we go? I'll go for the one primary and come back and join, sir.
No issue, no issue. Okay.
I'll be back, sir. I'll be back.
Okay, welcome.
Okay.
Balaji sir.
Am I audible?
Yes, sir, audible.
Yeah. Good to see Dr. Arunachalam after a long time. Thank you, friends. Thank you, Abbat. I think Dr. Kadri and hi. Yeah, I was about to talk, but I will show some 2 interesting cases of ACS, which you have done a couple of years back. We all know that I think Kalai has nicely elucidated about how to position imaging at this point of time with the complex coronary PCI. We all know IVUS and OCT characterizes the morphology, which is very important in assisting our decision making, especially in acute coronary syndrome. We all know the common cause for acute coronary syndrome is a plaque rupture and an eruptive calcific nodule or a plaque erosion. So probably, by identifying these plaque morphology, we'll be able to better manage these patients so that, we can address the long-term issues when it comes. This is a simple classical example of a thin cap fibroadenoma. A patient with acute anterowall MI, not acute, he was lysed elsewhere. He came to us for a further evaluation. If you could see between 6 and 9 o'clock, you could see a typical thin fibroadenoma. You could see some calcific nodule. Yeah. Oh, sorry. Could see some calcium, and we could see definitely there is a thin cap fibroadenoma. So this guy, underwent stenting. I'll show 2 interesting cases. A 59-year-old male, diabetic hypertensive, anterowall MI. He came to us after 3 days of an MI, moderate LV. This is angiogram. The lady was total. RCA had a non-flow limiting disease. We wired the pre-dilated with a 2 into 10 millimeter. Stented with a 2.5 into 38 millimeter. So he was put on DAPT, ticagrelor, ecosprin for a period of 1 year. Post dilatation done with 2.5, 3 serially, and this is a final picture. So eventually he was doing well. He was coming regularly for follow-up. He was very compliant. We did in 2023. After 1 year, usually we make it single antiplatelet switched over to clopidogrel. Within 4 weeks, he came to our emergency with a compressive chest pain for the last 1 day. So he told that he had similar episode twice in the past 1 week. And the RCA is eventually normal, like that of the previous angiogram. If you look at the LAD, you could see a thrombus floating proximal to the stent. So I thought, why this guy should develop a thrombus in the proximal edge. So anyway, I didn't do anything that day. If you could see, there is a definite thrombus overhanging the proximal edge of the stent. Started him on low molecular weight heparin, planned for a check angiogram and OCT after 3 days. Even after 3 days, he could see significant residual thrombus. So we crossed it. This is the pullback OCT. If you could see some minimal neointimal hyperplasia, it is exactly 1 year after the index procedure. Yeah. If you could see, this is the proximal edge of the stent. The stent apposition is good. Expansion is fine. But if you could see, there is some red thrombus proximal to the stent. There is a red thrombus. And if you could see, if I do another pullback, if you see, there is a plaque erosion which has happened proximal to the disease. I was not sure what to do, but there is a hanging thrombus at the proximal edge of the stent. It has not resolved. We gave GP2B3A inhibitors for 18 hours. Still the thrombus is hanging. So I don't want to take a chance. So there is some. So I went ahead to do a stenting overlapping the proximal distal stent. 3.5 into 18 millimeter was overlapped with the distal stent. So dilated, post-dilated with 3.5. So this is the pullback after OCT, after the stenting. There were some malapposition. So we used the same 3.5 balloon and we were 1 or 2 stents across the carina, but we had no option because we wanted to come up till the ostium. We went very high pressure. The final OCT showed good apposition. So this is at the Karina, so I do not want to go ahead and do it. This is the final picture. He is doing well. So 1 year over is coming for the follow-up. In February 2025, I did a TMT. It was negative. We walked close to 10 months. Another interesting case, a 58-year-old female from Pondicherry, diabetic hypertensive, obese lady. She had an inferior MI. She was lysed with SDK in March 2017 and underwent angioplasty at Pondicherry. She had a mild LV systolic dysfunction. Within 2 months, her antiplatelets was stopped because she had some vomiting with blood. It was like a malarious syndrome. She had some food poisoning. She vomited forcefully. And some physician has stopped the antiplatelets. So she developed again an ACS. This is the angiogram taken in 2017. So this is the index procedure. She had hematemesis after 1 year. So this is the initial procedure. This is not the second procedure. So she had an MI in March. And because she underwent this angioplasty in a government hospital in Pondicherry, she was taken up for the procedure after 2 months. March she underwent. She underwent a stenting which was 2.5 millimeter size stent. 1 year later, she had a hematemesis. Scopy showed antral gastritis. Antiplatelets were withdrawn. Within 5 days, she developed again reinfarct of the inferior wall, lysed with reticulase. After 1 month, she underwent an angiogram. It showed minimal CAD. If you see, the stent is patent. This was done on 4th April 2018 elsewhere. 1 week later, this lady had a bleeding PR. Again, stopped play antiplatelets by a surgeon. And she again had a ST elevation in the inferior leads, lysed with reticulase this time, initially with streptokinase. So she came to us for further management. Left system is normal. Angiographically, the RCA looked clean. But the ECG showed MI both in 2018 and the present episode. She had some significant ST elevation in the inferior leads. So I thought I should image and find out what is there, because angiographically the stent is looking good, no evidence of thrombus. So probably this is the OCT pullback of the RCA. There is some neointimal hyperplasia. But what was interesting to note was there was a significant uncovered stent stent. You could see some malposition which was significant. But what is interesting to note was there is some uncovered stented, even though we see commonly, but there is a circumferential, probably this is an underexpanded stent. So that is what I thought, that probably the sizing of the stent was not appropriate. So probably it is a late stent malposition or initial index procedure itself. The stent expansion was not good because imaging was not done. We had lots of discussion. We thought that one of the thought process at the time was post-dilated with a bigger sized balloon and leave it off. But she had recurrent stent thrombosis twice. We don't want to take a chance. We used a bigger size stent, 3.5. We dilated the stent with a 3.5 into 12 and stented again with a 3.5 40 millimeter regulating stent and post-dilated with a 3.5 balloon. Post OCT showed a well-opposed expanded stent. So she is coming for the follow-up. This is the final angiogram. This is almost 7 years got over. She just came for the follow-up. She is doing well. So OCT-defined coverage of stent was proposed to be related to with clinical safety in treated patients. And OCT-derived reduction of uncovered stent or neoatherosclerosis after PCI may be of use in preventing and predicting adverse cardiac events such as stent thrombosis. And the risk of stent thrombosis remains forever in patients who have got uncovered stent as in this case. Probably imaging definitely will help reduce complications, especially during the index procedures. Thank you. Open for discussion.
Thank you, Balaji sir. Very good, excellent 2 cases. With the first case, with the LAD thrombus, this thrombus was in the proximal edge of the stent, or it was actually from the de novo. It will be very difficult to define, but what was your assessment at the time, sir?
No. It is proximal to the stent. It was in the proximal portion, and it was even in the de novo vessel, it was there proximally.
Okay, so
you want to see this OCT once more? I can show if you want.
No issues there. So that actually we will be difficult to comment whether it is clopidogrel resistance or maybe it can be a block related issue also.
Yeah. If you see, there was some possible plaque erosion at the proximal edge between 9 and 12. So probably I'm not sure, but what
most probably plaque erosion.
This guy had a issue within 4 weeks. So I am not contemplating that clopidogrel. We sent clopidogrel resistant, but it was not significant.
Yeah, okay. So probably plaque erosion, correct.
Because we did not have any obvious reasons for this guy, because he was very, very compliant. He is a health inspector.
Okay. So regarding the second case, I think this very important thing is it tells us the lesson that we should not be complacent when we are treating stent thrombosis, or since she had twice thrombolized, I think.
Twice after the index event, yeah.
So that is very good. So there was a very clear-cut malopposition in the mid part of the stent. And for the beginners, we should understand that it can be malopposition from the index event, or it can be an acquired malopposition also in some cases where there is positive remodeling of the vessel after the stent. So the vessel walls moves away from the stent. So sometimes, even though we have done the index procedure with an imaging and documenting stent opposition, very good stent expansion opposition, sometimes there is a particular issue called acquired malopposition, where because of the positive remodeling of the vessel, vessel wall moves away from the stent. So it is very important that whenever we have the question, we should do the imaging. And what is the reason for your stent in that case? We can, because of the mid part of the stent, it can be left with balloon also. So what was your thought process of that?
See, that is what we had lots of discussion. We did not do, all of us had a discussion. So many of us felt that, maybe sometimes, if the tissue healing is not better, in spite of that, if she gets something, we have dilated multiple times, better to cover it with a stent, which is of, with a great data. So probably we used, I can tell you the stent, we used the R0 stent that time. It was in 2018, thinner stent. I thought, if it could cover the entire stent. So I was not very confident in leaving the stent at that point with just a dilatation, because I don't know, it could, maybe we could have left it at that point without any stenting. That was one discussion, but we stented it that day. Yeah.
Stenting is also good in one aspect, that you are going to have a healing from the first point, so that you can have some drug elution for the next 4 to 6 months. That is also an option. So very good 2 cases, sir. Over to Dr. Arnaz.
Yeah, this is the first case. This is away from the stent. If you could see between 9 and 12, there is some possible plaque rupture or erosion between 9 and 12. So the made us think that, probably.
Yeah,
that's
sure, sir. There's a clear-cut case of plaque issue.
Sir, one question, whether OCT can help in deciding whether we can use DEB in acute coronary syndrome. For example, if there is a plaque erosion or something like that.
At this point of time, we don't have data for DEB in acute coronary syndrome, unless you are trying to treat a small caliber vessel. And one of the thing is, you cannot have a grade 4 or 5 thrombus and then plan for a drug-eluting balloon. So maybe we need some more data to recommend drug-eluting balloon at this point of time. But I think.
For example, sir, if there is a plaque erosion, there is no need for stenting, something like that.
Yeah.
So in such cases, whether we can use DEB or we can leave it.
Yeah, we are trying for some cases off late, but I cannot recommend because it is off-label recommendation at this point of time. If you ask me, I've been trying in my cases, but not in an acute anterior MI, say post-oral MI, OM disease, and inferior MI where you have a PDA occlusion. I've been doing for the past couple of months, 6 to 8 months, especially in young individuals, but not when it comes for the primary PCA. It is a evolved MI. Suppose he gets sliced elsewhere and comes to us for further management, is stable, maybe to give the option of native vessel remodeling. We are trying it out, even though it is off-label at this point of time. I think OCT do not guide us whether it can be left for a drug-eluting balloon or a DES, I believe. Dr. Kadiriasan or Arunachalam, you want to throw some highlight on this?
So we have been individualizing here. So in younger age groups with OM disease or PDA, sometimes we err on the side of DCB. And also in older age, 80 years, 85 years, when you do when they come for the ACS and then when they have some issues with the antiplatelets, and when your initial balloon, the pre-dilatation you do with the balloon 1:1, and you have a good lumen gain without residual disease, with less than 20-30% residual disease. In the extremes of age, so older age group, also we have done few cases. But as Dr. Balaji said, it is not the standard of care. It should be individualized and it will be off-label. But it is used off-label in many centers. We have to wait for the results.
Yeah, one more thing. See, Arun said, so vulnerable plaque, we don't have data to recommend stenting. But if it creates an acute coronary syndrome, whether it is a non-ST elevation MI or ST elevation MI, it is no more vulnerable. It has created an event. So probably the decision should be clinician based, because if it comes with an acute MI, probably the best way, the flow is not good, best way is to do a stenting. Unless you are seeing only thrombus, you can always treat him with antiplatelet anticoagulation and then plan for an imaging to decide on the strategy. If only a plaque erosion, rest of the lumen is fine, probably now we have got other modality to quantify the lipid core burden to assess whether these patients will have a recurrence or not. OCT can only characterize plaque morphology can be identified. So probably if we have some other devices which can quantify the plaque burden, so probably it can help us decide the strategy. Like I was nurse.
Thank you.
As Arman sir, as rightly said by Balaji sir and Kadiriasan sir, we don't have, to be honest, guts to just dip the proximal LAD or proximal RCA to come back. We are now using it for PDA, PLV, OMs or diagonal like that. And another thing, if there is more thrombus is there, DEB will not work. That's one thing. And regarding Balaji sir case, 2 cases, very interesting cases. Thank you, sir. And if you see the first case, as he said that there was a plaque rupture, and quite naturally, in spite of 48 hours of low molecular weight and again GP2B for another 18 hours, it's quite natural to have a very safety, because young guy, better to put a stent and come back, and that's what done. And if you carefully see that he showed malopposition and went with aggressive dilatation, there was some elongation into POC. This you can also see. And regarding second case, what is very interesting is she was admitted 2 times for bleeding, but on 5th day stent thrombus, they lysed these people with retiplase. Yeah. I don't have the guts to use retiplase because she was 2 times bleeding.
It was.
I think they would have referred to interventional cardiologist to do.
No. It was done at Pondicherry. Yeah, Pondicherry Government Hospital. She had gone to. She's working in Pondicherry as a she's a paramedical staff there.
Yes, sir. That's what I said. I'm not saying in your hospital. I'm saying that people would have at least taken for intervention, because she had bleeding Then stent thrombus, again putting reticulus is a very high risk. She may again have a severe bleed and may collapse and all. And regarding stenting, that is okay, individualized to you. So I may come with a balloon, that's different, but nice cases, sir. So we'll go to the next presentation. So next is I invite Dr. Palanivel Rajan from Apollo Greens Lane to have a talk on OCT and ISR. Over to Dr. Palanivel.
Good evening, sir. Thank you for this opportunity. So I'm going to talk about OCT and ISR. I will discuss an interesting case. So the patient is a patient of systemic hypertension, diabetic, and present with chronic stable angina. We had a history of angiogram done in 2013, which showed a single vessel disease of LAD. And in 2013, he was stented with a 323 Fromus drug-eluting stent. And because of the symptoms, he underwent a check angiogram in 24/5/25. It revealed double vessel disease. The proximal LAD ISR of 90% and distal LCX showed 90%. And the patient's LV was normal. So this is an angiogram showing the in-stent renosis of the proximal LAD stent, proximal to mid-LAD stent. We were able to do an OCT at the outset, but the clearance was not just after the tighter point of the lesion. So there was a significant artifacts, and the proximal part of the lesion we were able to visualize. It showed a significantly tight lesion with lumen area of 0.74 square millimeter with layered
morning
blocks.
Sorry.
So by Mehran classification, we see it could be ISR pattern 3 proliferative because there is some amount of lesion proximal and distal to the stent as well. By Waxman, by right now, we are sure that it is neoatherosclerosis, non-calcified type, that is type 2B. This is the OCT run. So we did a 2 millimeter NC dilation at the tightest point, and we repeated the OCT. The OCT showed that. I'll slowly play the OCT. This is a normal unstented segment. The stent starts. Where the stent starts, there is significant amount of neointimal hyperplasia at the proximal part of the stent. In the mid part of the stent, we are able to appreciate cholesterol crystals and foamy macrophages. And in the distal part of stent, it again goes into homogeneous pattern. So this an interesting reveal was present that the mid part of the stent was underexpanded when compared to the distal and the proximal part of the stent. The mid stent diameter was only 2.66, when the mid DL was 3.63. So we thought that it could be a mixed etiology and a type 3 by Waxman. We repeated the NC balloon dilation with a 3 mm NC balloon and repeated the OCT pullback. The OCT pullback showed that the distal and the proximal edge of the stent, which had the neointimal hyperplasia, was practically untouched, while the neoatherosclerosis part, which was in the middle part of the stent, had good block modification. So what to do next? We thought that we will do an LCA. We took an 1.4 catheter and we did a target lacing. We saw by the co-recession where is the point of the lesions, and we did a target lacing at the homogeneous IMS segment, and then we repeated the OCT. By this time, it showed that there was significant plaque modification in the proximal and the distal edge of the stent both. So we can see nearly tearing of the intima here throughout the segment from the proximal to the distal edge. We can see the plaque modification here. We didn't go outside the stent. So the pre and post compare pullbacks in anterior future showed that the area was almost 4.8, there was an increase to 5.1, but there was significant plaque disruption because of the lacing defect. So we prepared again with a 3 mm balloon, and we stented with a 333 mm drug-eluting stent. So the final OCT showed that the stent expansion was good, and in the proximal distal edge, there was almost no plaque sandwich. The proximal distal edge was a good expansion and almost nil plaque sandwich because of the lacing effect. So the comparable bugs area which was 0.9 initially increased to 7.05, and it was a good stent expansion. This is the final angiogram of the patient. The take-home message is that the dynamic oscillation is an ideal tool to identify the target spot, homogeneous or neoatherosclerosis, to choose the ideal selection of tools in any ISR. ELGA has helped to vaporize the homogeneous new fibrotic volume, and it changed the texture of the ISR, leading to negligible plaque sandwich. Thank you.
So that was nice presentation. Dr. Palana, you tried 0.9 millimeter laser catheter, or upfront you went with 1.4?
Upfront we went with 1.4.
1.4. Huh? Okay. So that's a big advantage of lacing. The sandwich, whatever you do with any cutting balloon, whether it's Apata or any Boston cutting balloon, anything, you will have the tissues in between. The big advantage of laser is the sandwich part will be very less, and there will be definitely the MSA after lacing in ISR is always a edge than only going with cutting balloon or scoring balloons. So this prevents a further ISR ratio is reduced. That is one. The lumen gain, acute lumen gain is better. That is clearly shown by Dr. Pallivel.
Yeah, very good guess, Pallivel. I think you also showed the neoatherosclerotic block in a very the classical way. So we always have macrophages with cholesterol crystals, and sometimes also intrastent calcium also in some cases. I think this patient had an ISR after maybe this is after 10 years, correct? 12 years from the index event.
Yes, 12 years from the index event. Yes.
12 years. So a very good demonstration of the OCT, and it is very you have classically shown that how to use the lacing in to reduce the tissue volume. So what the practical point in this case is, we should not disturb the plaque, we should reduce the plaque volume. So if you reduce the plaque volume, then only the sandwich tissue which is between the first stent and the stent what we are going to do, which is called the sandwiched part, so that volume has to be less. To make it less, we should make sure that we reduce the tissue volume of the ISR, which laser does it by vaporizing the tissue. And the important thing is the technique has to be proper. We have to use the proper catheter, and I would like to ask Pallivel Rajan to enlighten the audience what is his method, how do you choose 0.9, 1.4, how do you choose the catheter, lacing catheter for the beginners, you can tell, and then also Armugam also can tell, because I think Arnachalam is using a lot of laser in these days. Palnivel, can you tell us?
So ideally, we will start with 0.9 only. But in that particular case, the 0.9 catheter was not working, so we had to shift to 1.4. So we will start with the saline lacing only. And in particular cases with the ISR, where it is resistant, we can switch to saline plus contrast, or we can use blood lacing. And if it is still resistant, particularly in cases of calcium, we can use contrast lacing as well. So I will preferably start with saline clearance even before the lacing starts. So start the clearance before the lacing happens, do the lacing, continue the lacing up to when the saline is present, and stop the lacing. This is what advice with the to proceed with the lacing.
So regarding this catheter sizes, most of the time 0.9 millimeter will do, sir. It is not like that as per recommendation, simply you can add 1 millimeter like that, but not like that. Sometimes this 0.9 millimeter, if you you have to move the catheter less than 0.5 millimeter per second. When you are moving, it will not produce 0.9 millimeter diameter. It is set to produce 1.8 to 2.5 millimeter, cutting slowly the tissues around. So this 1.4, it is ideal if you minimum 3 millimeter the diameter is there. So especially proximal LAD or proximal RCA or SVG grafts, where you have chunk of thrombus and the grafts are big sizes, definitely there 1.5 millimeter works. Otherwise, most of the time 0.9 millimeter. And if the diameter is less than 2.5 millimeter vessel, caution, because it's almost a relative contraindication not to use it, because there is more chance of perforation.
Yeah, his point is well taken. So particularly here, I think the co-registration has helped, the dynamic co-registration has helped in a big way. I think you can use the laser in a very focal point. So where both the technology, the co-registration of the OCT and also the selection of the tool to reduce the ISR volume, tissue volume. So both has helped. I think this is where to prevent an event and to make sure that you achieve the best of the mean stent area, where both the technology helps. So with the current Ultreon co-registration with the lab, it is very easy to make sure that we have a very focal treatment for in this kind of cases. So, so one thing is what is your experience? This is question is to Dr. Arnachalam for the intrastent calcium or peristent calcium and laser atherectomy.
Sir, I said that saline lacing you have to do it, but when there is intrastent calcium, first we go with saline lacing, and then as said blood lacing. Blood lacing means we will not, the second operator will not give saline, so directly we will be lacing. But inside the stent, you can confidently do contrast lacing. And if there is intrastent calcium, that doesn't matter. Even peristent calcium, this contrast lacing will modify the tissues around the stent, and the peristent calcium, it is a very ideal choice. After that, when you take NC, no need to use any cutting balloon or aperture scoring balloons after lacing, sir, because the laser would have modified the tissues. So simply you take 1:1 size NC and just you dilate, and if you get a good expansion, that is well and good. So that is what in peristent calcium, definitely contrast lacing will be of very much useful. Followed by that, you can use a 1:1 size, depending on imaging, NC balloon simply, and can dilate at atmospheres of 12 to 14 atmospheres, something like that, and good expansion is that, and that's all.
Yeah. So that point is well taken. Any other questions? I think as we see lots of stent failure with imaging nowadays, particularly the OCT, we now have a very straightforward and very informative way of treating the cases, where we can do the DCB, where we have to stent, and particularly near atherosclerotic lesions, definitely we have to stent to get the good outcomes. So I think stent failure is the one area where OCT plays a bigger role, because it gives the information as if we are doing the histology of the vessel. So much of information, and that helps in what we can call the at least precision treatment, precision PCI from this point.
And as rightly said, for stent failure, imaging is a must. It is not luxury, it is a must, whether OCT has a edge over IVS. So thank you, Palni Rajan. So next we go to Dr. Arun Arokya Rajesh. Is a consultant from Vandalur One Health Hospital. So he'll be presenting an interesting topic, 2 cases, 1 solution. Over to you, Dr. Arun.
Good evening, sir. Actually, Mr. Vignesh will be sharing the slides. I'm asked to present on an emergency basis.
Hello.
Can you hear me, sir? Hello.
Yeah, please tell, sir.
Yes, sir. Yes, sir. Mr. Vignesh will be sharing the slides, sir. I will be speaking, sir. Yeah. Okay, thank you. Sir. The classic, I'm going to present a case on classic DK crusher. Next slide. The case is a 47-year-old gentleman with known diabetic and hypertension. The patient was diagnosed to have a CAD-ACS evolved anticoagulomai 1 month ago. Patient was treated elsewhere with he was lysed with tenector place, and angio was done, which revealed left main with the double vessel disease. Plan was to go for an OCT guided left main bifurcation PCI. Next slide, please. This is a baseline angiogram which was done 1 month ago in Pondicherry. As you can see, there is a distal left main 70% occlusion. Previous slide, 70% occlusion, followed by bifurcation lesion of osteoproximal LAD and osteoproximal LCX. Next slide, please. RC was relatively disease free. Next slide. This after initial balloon dilatation, and OCT pullback was done. Pre-stenting OCT pullback was done, and for both LAD and LCX, so that we proceed with the LM bifurcation stenting. This is the first pullback, which shows the LADs has some mid block rupture. Mid LAD had a block rupture, and ostial LAD had a tight lesion. And LCX had the 90% tight lesion at the ostium. Next slide, please. Next slide. These are the reference ranges for the stent placement. As you can see, the LCX ostium had a tight 90% occlusion, followed by LM had a distal LM had a 2.1 millimeter diameter. Next slide, please. Vignesh, next slide. This is the block causing. This was the block causing anticoagulomai 1 month ago, which was in the mid LAD region. After immediately adjacent to the block rupture, there was a tight, lipid pool. Next slide, please. Initially, the mid LAD was stented with the 2.75 into 24 balloon, followed by we proceeded for bifurcation left main stenting. Lesion was prepared with the cutting balloon of 2.75 into 13. Aperta was used. It was used both in the LAD and LCX. Then the proximal LCX was stented with the 2.75 into 18 millimeters drug eluting stent. Next slide, please. Next slide. The initial part of the L6 stent was crushed with initially with the 2.75 into 8 millimeter balloon crush, followed by a pot crush of 4.5 into 8 millimeters. Next slide, please. Next slide. Then the balloon wire recross was done. It was the balloon was taken out and it was crossed by a non-proximal stent strut. Then the first kissing balloon inflation of L6 and LAD was done. Next slide. Next slide. Then the main branch was stented with 3.5 into 18. That is LM to LAD crossover was done. Then the pot was done with 4.5 into 8 millimeters balloon. This is the first pot. The first one was a pot crush. This is the first pot actually. Then the jail wire was taken out and it was next slide. Vignesh, next slide. Then The L6 ostium was opened up with an 1.5 into 12 millimeters balloon for opening up the strut, followed by a second kissing balloon inflation at L6, and LED ostium was done using the respective balloons. Then the final part was done, which is the second part. Then the final OCT run was taken. Next slide, please. Vignesh, next slide. This is the final OCT run. Showing the mid LED stent followed by a proximal LED stent, showing the L6 ostium was opened up properly. Vignesh, next slide. This is the 3D picture of the same. So I'm presenting in this case basically to, pronounce the use of imaging in classic decay crush. Even for classic decay crush, right these days we are using imaging so that we can have a better result. Thank you.
Yeah, a very good case, Arun. I think very well demonstrated with the OCT imaging also. So the one important step that everyone should understand is what Arun showed is the pod crush. So whenever we are doing the left main, whenever you do a LCX as the first stent and then you crush, so the distal part of the stent will be crushed by the usual LED sized balloon, but the proximal strut will not be crushed because you have a very large left main. So you should use a larger balloon sized to the left main to crush the proximal most part of the stent which is crushed. So pod crush is the term used for that. And always we have to, in decay crush, in all crush techniques, we have to use, whenever we recross, we have to recross non-distal. So it should be either proximal or mid. So we use the term non-distal, it should not be distal unless in provisional technique. So that's the thing. And in case of you are not able to cross with the balloon. So other important step is after you have the two stents, or after whenever you go for the first kissing inflation or the second kissing inflation, if you are not able to advance the balloon, we should not push and try to pressurize the balloon. Always understand, most of the time the wire would have been in a strut where there is a link. So you should recross with a different strut, and then the balloon will easily cross. So when in doubt, always do the imaging when the balloon is not getting across in all two stent techniques. So very well done, Arun. Good case. Over to Arunachal.
Yeah, a nice presentation, Dr. Arun. And you have clearly told that, and that what the October trial was also saying that in bifurcation lesions, definitely OCT has the role. And as rightly pointed by Dr. Kadrisan, this first cross should be non-distal, and second during kiss it should be distal. And so there is one question in the chat box. In some scenarios, after stent deployment, slow flow phenomena occurs. How it occurs and avoid that situation? Kadrisan, sir.
So slow flow, the most important cause is the microembolization from the plaque. So it can be a thrombotic plaque or it can be a lipidic plaque. So first thing is we should have a good antiplatelet on board. So if the microembolization happens, it can be taken care of. But in certain cases where there is a lipidic plaque, once you implant the stent and if you have a plaque prolapse or if you have a lipidic plaque, there will be platelet activation. So local platelet activation which can cause the slow flow. But the most important reason is when you do the balloon, when you do the pre-dilatation or when you do the post-dilatation, there is a further disruption and microembolization of the plaque which goes into the distal circulation and causes the slow flow. So one important management should be the whatever nitroglycerin, NTG, nicotinidyl, adenosine, nitroprusside, whatever you give. Most of the time in severe slow flow, it does not reach the distal circulation. So what we have understood is you give the drug as distal as possible. You either take the perfusion. We normally do either with the aspiration catheter taken deep inside the vessel and then give the drug, whether it is NTG, adenosine, whatever. Or nowadays you also started using, you take the usual balloon and you can put 2 or 3 holes in the balloon and you can deliver the drug also. So deliver the drugs as distal as possible if you are having a refractory slow flow.
Yeah, one thing is sodium nitroprusside. If the BP permits, it's if you keep the, as Sir said, the aspiration catheter or microcatheter down, and you can give the doses will be also be very less, and you can give nitroprusside if the BP permits. It's one of the good drug, or adenosine and nicorandil. Nitroglycerin mainly produces major epicardial vessel dilatation, and you can avoid that because it may produce drop in BP. So if slow flow, another thing you are also think about any dissections also. Sometimes we think that it is there, so you can take in two orthogonal views and can see that, or if you have image, you put a catheter and see. So we had a nice discussion today, the presentations. Any other contributions from other people? Dr. Vignesh, Dr. Radha, panelists, and any other people you want to contribute anything? So clearly what I feel is I'm very happy to say that we started last January with the AOCT, and we have done more than 650 pullbacks so far. And what I feel very comfortable is in ACS, as Mohan said, today we did a case. It was very fast because it was a disease where you can see that middle of LAD 3.3 was the EL and LM was showing 4.5. In between is not there. So we directly take a 3 millimeter aperture balloon, go with preparation and all. And fast you can see the size in ACS, because if a distal lumen is 2.2 and proximally it is showing some 3, what should be 2 stents if you want to use faster and all. So this you can fast prepare the lumen based on that stent size, and also post dilatation balloons. You can ask fast to prepare your technician to put 2.5 for distal and 3. So all these things it images. And one other, after today case I discussed, but finishing when you took a run distal, it was not, we are not able to cross. So we did from mid of the thing to proximal stent. The mid stent was showing 69%. So that we just angiocore registration done and post dilated only that segment. So if you are constantly post dilating again back, lot of tissue protrusions will be there. One other thing what we see now is after stenting, if the stent looks under expanded, if you image, most of the time in ACS it is the tissue protrusion which is showing like the stent under expansion. But if you see in the stent boost, it will be expanded. So if you're going on looking at the dye injection under expansion, if you are post dilating again, you get more tissue protrusion, and the risk of stent thrombus increases. And except in one subset of diffuse LAD lesion or diffuse RCA, where ACS, most of the ACS is able to do pre and post, and most 90% of any STEMI or non-STEMI, any ACS, I take mostly, unless a distal, a pullback, because I want to confirm no dissection, no malapposition, and that is a very, we have a peaceful life to have a sleep on that night. So because we cannot, like in a tertiary center and in a 3-tier city, we cannot convince the patient stent thrombus. Everywhere it is there, but it's very risky for us in such small cities and all. So definitely ACS using post pullback, I'm using almost 90-95% of the time. Pre pullback, my percentage is somewhere between 50 to 60% usage. If there is more thrombus, more diffuse long lesion, I try to avoid. Otherwise, ACS are able to do a lot of pullbacks, and it gives a lot of advantage. And as said by Arnam sir, if you feel the spasm, you can see the thickened EL. So that itself shows that the artery is under spasm. You can either give more NTG and can again do, or if you feel the what if dye usage is more, you can try saline. If not, you can just think that you can little upsize 0.25 or 0.5 depending on the size of the proximal or mid LAD. So very nice, Kadresan sir and Balani sir, presenters Kalai Chelvan and Arun and everybody, Palnivel Rajan. So if anybody is there to contribute, you can say, otherwise we will conclude. Ram, anything you want to say? You are
Sir, yes, sir. Sir, actually, this is the part 8, sir. So ACS, CCS guidelines and recommendation after class only evidence. So continuously, we've been doing this program for last 6 months. So this is the 8th event, sir. So every time, actually, whenever actually we're requesting you to be there as a chair or moderator for a panel, actually always the contribution from you actually it is excellent, sir. And today is also excellent moderation. And the Kadiration, sir, actually definitely actually it's like a atlas of OCT, like this kind of each and every cases in-depth deep dive discussion you've given, sir. I think participants whomsoever they're seeing this definitely get more advantage and understanding about that imaging. Thank you so much, Kadiration, sir. And thank you so much, Panivardan, sir, Kalai Chelvan, sir, and Balaji, sir, and Arumugan, sir, everyone. And actually excellent contribution from each and everyone. And this part actually we will continue this. So at 3 weeks once, 4 weeks once, we're going to continue this session. I think yesterday also we did one session that was a 7. This is the 8. I think overall together all 8 sessions. So totally some 750 doctors has participated this session, sir. So there's a lot of penetration about that imaging knowledge that has happened because of you doctors. Thank you so much, sir, and it's really very excellent session on this thing, sir. And actually, thank you so much for my team also, Mr. Vignesh and Mr. Sari. They are the metal behind actually this kind of webinar program, particularly OCT related stuff. Thank you so much, and once again, thanks to everyone. So thanks a lot.
I thank all the speakers, moderators, chairpersons, everybody. Thank you and all. Good night. Bye.
Thank you, sir.
The meeting is concluded. Vignesh, sir?
Yes, concluded. Finished.
The meeting, okay, I'm ending the meeting now, sir.
Yeah.